So IBS is incredibly common. Colon cancer is also pretty common. It is the second leading cause of cancer death in the United States. And there is significant overlap between IBS and colon cancer symptoms. And that overlap is one of the most important things to address when something doesn't feel right with your gut. Now, every single week in my clinic and at the hospitals here in Las Vegas, I am seeing patients with gastrointestinal symptoms. We're talking about abdominal pain, bloating, changes in their bowel habits, and a lot of those people, very understandably, are scared. They think it may be something serious. A lot of them have cancer in the back of their mind. And so today what I want to do is give you a very clear framework for understanding the differences between IBS and colon cancer, what doctors are actually looking for, and when you need to do something about it. I also want to talk about something that catches a lot of people off guard, which is that if you already have IBS, there is a trap you can fall into that can cause you to miss something very important. And I want to come back to that later in the video. But first, let me be clear about something. Most people with gut symptoms do not have cancer. The vast majority of the time, bowel symptoms have a benign explanation. That much is true. However, there are certain patterns, certain combinations of symptoms, and certain changes that we are trained to pick up on as red flags. I see them all the time in my clinical practice out here in Las Vegas. And by the end of this video, you are going to know exactly what those are. If you're new here, my name is Dr. Matthew Glover. I'm a board-certified gastroenterologist. I practice in Las Vegas, Nevada, and I do thousands of colonoscopies and endoscopies every year. The gut is what I do all day, every day. If you find value from these videos, consider giving the video a like and subscribe to the channel. Subscribing helps others find these videos, and if this information gets just one person to identify the warning signs and stop colon cancer before it becomes advanced, then it was all worth it. Okay, let's get into it. So let's start with IBS, irritable bowel syndrome. IBS affects somewhere between 10 to 15% of the people in the United States. That's around 45 million people. It's one of the most common reasons I see patients in my clinic. And I want to be clear about something up front. IBS is real. It's not in your head. It causes genuine, sometimes debilitating symptoms. And people who have it are often told just to deal with it or change their diet, and that's that. And that is frustrating because it is a serious condition. So what actually is it? Well, IBS is what we call a functional bowel disorder. And that word, functional, has a specific meaning in medicine. It means that there is no structural damage. There is nothing physically wrong with you that we can see. If I put a camera in your colon, and that's exactly what a colonoscopy is, it would look completely normal. The lining is healthy. There's no inflammation. There's no tumor. Nothing abnormal at all. The bowel is working. It's just not working optimally. It's not cancer. It's not damage of any kind. It's just a gut that's a bit dysregulated in the way it functions. And the diagnosis of IBS isn't made by finding something on a scan or a blood test or a colonoscopy. It's made based on symptoms that a patient describes, what you describe to me in clinic. And that's a really important point because it means it's what we call a clinical diagnosis. I'm listening to what you're telling me and recognizing a certain picture. So what does that picture actually look like? Well, it's typically recurrent abdominal pain, pain that keeps coming back, often quite crampy, often lower down in the abdomen, and it's connected to going to the bathroom. Either it comes on when you need to go, or it gets better after you go, sometimes both. That connection to the bowel, that is one of the key signatures of IBS. You can also have changes in stool frequency or consistency, going more often, going less, looser stools or diarrhea, periods of constipation, sometimes alternating between the two. Bloating is really common as well. That uncomfortable fullness and distension that tends to build up throughout the day and ease off overnight. And mucus in the stool is something a lot of people notice and worry about, but it's actually a far more common feature of IBS than anything sinister. If that's the only thing going on, it's usually quite reassuring. Now, crucially with IBS, this tends to be something that's been going on for a long time, months, often years. IBS is a long-standing, chronic, fluctuating condition. It waxes and wanes. It's better sometimes, it's worse other times. Stress often makes it worse. I see that with my patients constantly. Certain foods may be triggers as well. Things like onions, garlic, beans, wheat, depending on the person. Everyone is a little bit different. Anxiety is another big one. And I think that the connection between the gut and mental health is far more powerful than most people realize. There is a very real mind-gut interaction and interplay. And IBS typically starts in younger people, often in your 20s and 30s, sometimes teens. Part of the reason I think IBS rates are rising in younger people, and this is just my own opinion here, is processed food. I think that in a few decades, we're going to look back at what this stuff has done to people's GI gut health, and it's going to be one of those things where the evidence was always there. We just didn't want to see it. So IBS, it's chronic, fluctuating, connected to triggers, normal looking bowel on a camera, unremarkable workup. Keep that in mind. Now let's talk about colon cancer. And I want to explain something here that most people fully don't understand, which is how colon cancer actually develops. Because when you understand that, everything else about the symptoms makes a lot more sense. Colon cancer kills around 50,000 Americans every year. It is one of the most common cancers in the Western world. And here's the thing that makes that number so frustrating from where I stand. It is one of the most treatable cancers we have when it's caught early. The 5-year survival rate for colon cancer caught at its earliest stage is over 90%. However, when it's caught late, that number drops to below 15%. So the gap between those two outcomes isn't really about what treatment we are giving. It's about timing. And timing is knowing what to look for. Now, the way colon cancer develops is really important to understand. The vast majority of colon cancers, over 90% of them, start as a small growth in the lining of the colon called a polyp. These are really common. I find them all the time during colonoscopies in people who feel completely fine. They have zero symptoms. Most polyps are totally benign and never cause a problem. But certain types of polyps, specifically what we call adenomas, have the potential to slowly transform into cancer. And slowly here is the key word. This process typically takes around 10 years. A polyp grows very gradually. The cells accumulate mutations over years and years. And at some point, those changes tip into cancer and it starts invading into the bowel wall. That 10-year window is everything. That is our opportunity. That is why a colonoscopy is so powerful. I go in, I find the polyp, I remove it right then and there during the procedure. And the cancer that would have otherwise developed years from now never happens. It is one of the most effective preventive tools in all of medicine. The problem is that for most of those 10 years, there are no symptoms. The polyp is there. It might be turning into something dangerous, and you feel completely fine. You have no idea. By the time symptoms actually show up, things are usually more advanced. And when those symptoms do come, and here's often the core problem, they often look exactly like IBS. That is the overlap. That is what makes this so difficult. So let me just be honest about this. IBS and colon cancer can both cause abdominal pain and cramping, changes in bowel habits, diarrhea, constipation, going more or less, bloating, that feeling of not fully emptying when you use the bathroom, and in certain presentations, even some rectal bleeding. So when a patient comes in with those symptoms, I cannot tell from symptoms alone which one it is. Nobody can. That's why we have a colonoscopy. That's what it's for. But what I can do, and what I want to do right now for you, is walk through the specific patterns and combinations that, in my experience for doing this every day, separate the two. Because even though the symptoms overlap, the characteristic of those symptoms and the context around them are often very different. And those differences matter. So let me just lay this out very clearly. With IBS, symptoms tend to come and go. They fluctuate. They've been there for months, sometimes years. The pain is often linked to going to the bathroom and usually better afterwards. There is no unexplained weight loss, no anemia, and it tends to correlate with stress or certain foods. and it typically starts in younger people. Now, with colon cancer, the changes tend to be fairly new, something that wasn't there a few weeks ago, or a noticeable shift from what was normal for you. The symptoms persist and they progress. They don't really go away or get better. If anything, they tend to get worse. There may be blood, there may be unexplained weight loss, there may be fatigue due to anemia, and there are some key specific things I look for that I want to go through with you now. These are the things that when a patient mentions them to me in clinic, the hair stands up on the back of my neck. These are not things to monitor at home for another 3 months. These are reasons to pick up the phone and see a gastroenterologist. Number 1, new symptoms that do not go away. This is the most important distinguishing feature. IBS is defined by variability. That is almost its signature. The symptoms come and go. They have a relationship with identifiable triggers. They ease off, good weeks, bad weeks, a stressful period kicks off a flare, and then things settle back down. Colon cancer behaves differently. The symptoms start, and then they don't really go away. They might vary in intensity, but there is a progressive, relentless quality to them. They're just there. And over weeks and over months, they are getting worse, not better. There is no clear trigger. Nothing settles them. They are just persistent and they progress. That distinction, while it's not absolute, is one of the most clinically important things I assess for. If your symptoms started, they're 4 to 5 weeks in now, and they're not improving, that is when I need to see you in clinic. Number 2, blood in the stool. Now, I want to be careful here. Blood in the stool is incredibly common, and the most common cause by far is hemorrhoids. Most adults will have hemorrhoids at some point in their life. They bleed, sometimes quite a lot. And so when someone notices bright red blood on the toilet paper, hemorrhoids are the most likely explanation. That's just statistically fact. But hemorrhoids are not always the explanation. A new rectal bleeding you haven't had before, should always be properly assessed. Not assumed, assessed. All patients who present to me in clinic with rectal bleeding get a colonoscopy unless they've had one in the recent past. Never assume hemorrhoids. I recently had a 22-year-old female who came to me for rectal bleeding 2 to 3 weeks after giving birth. It was a perfect story for hemorrhoids, and 2 GIs had already brushed off her symptoms, saying it was just hemorrhoids. But she knew something was wrong, and I stuck to my rule of that all rectal bleeding gets a colonoscopy. Unfortunately, she was right. Something was wrong. She had a large rectal cancer. But there's a good end to this story. The good news is that it was not metastatic, and she is currently undergoing chemoradiation and is expected to have a great outcome. I only mention this clinical anecdote to emphasize the importance of not ignoring rectal bleeding. The characteristic of the bleeding also matters to me. Blood just on the toilet paper after going, that is more consistent with a lower source, like a hemorrhoid. However, blood that appears to be mixed into the stool itself, darker, incorporated throughout it, rather than just coating the surface, that concerns me more, because it tells me that the bleeding is usually coming from somewhere higher up in the colon. But regardless of how it's presenting, new rectal bleeding gets investigated. I don't care if you're 30 years old and you're convinced it's just a hemorrhoid. Get it checked out. Number 3, unexplained weight loss. Unexplained weight loss is one of the most important red flags in all of medicine, not just gastroenterology. And when I say unexplained, I mean meaningful. 5% or more of your body weight in 6 to 12 months without any intentional change in your diet or exercise. Colon cancer, like many cancers, triggers a systemic response in the body. The tumor cannibalizes and affects how you metabolize energy. Appetite drops. Weight comes off without you even trying to lose it. If your clothes are fitting differently and you haven't done anything to make that happen, that is something I need to know about. Number 4, fatigue that doesn't make sense. This one surprises people. Fatigue is the most common complaint in general medicine. Everyone is tired, and the overwhelming majority of the time, it's explained by lifestyle, sleep, stress, or work. But fatigue from colon cancer has a specific mechanism. A tumor in the colon can bleed, and it doesn't always bleed in a way that you would ever notice. The bleeding can be so slow, so gradual, that you will never see anything obvious in the toilet. We call this an occult bleed. An analogy I like to give my patients is think of this like a pin-sized hole in your bathtub, too small to see, but will consistently leak. And over weeks to months, that steady low-level blood loss depletes your iron. Your iron stores drop. You develop iron deficiency anemia, and the result is a fatigue that is different in quality from ordinary tiredness. A deep, exhausted feeling that just doesn't get better no matter how much you sleep. I have had patients come in for completely unrelated things. We run a basic blood panel, and their hemoglobin and/or iron profile and ferritin is critically low. They had been chalking it up to stress or getting older. They had no idea. Iron deficiency anemia in any adult without a clear explanation for it, heavy periods, something dietary, something that accounts for it, needs a upper endoscopy and a colonoscopy. The guidelines even state that menstruating females should get a upper and lower endoscopy for iron deficiency anemia. That's not a maybe, that's an absolute. Number 5, symptoms that wake you up from sleep. This one is short, but really important. IBS does not generally wake people up at night. The gut is calmer when you're asleep. IBS flares are driven by food, stress, gut motility, things that tend to quiet down overnight. If abdominal pain is waking you up, if you're getting up at 3 a.m. to use the bathroom, and that's new, if your gut symptoms or pain are breaking your sleep consistently, that is not a typical IBS pattern. Anything that pulls you out of sleep because of gut symptoms warrants investigation. Number 6, new symptoms after the age of 45 or any symptoms with a family history. The risk of colon cancer rises steeply with age. The current U.S. recommendation is to start screening at age 45 for average risk individuals. If you are over 45 and you've never had a colonoscopy and you are developing new bowel symptoms, that is a conversation you need to have with your doctor this week, not your annual physical this week. And a family history changes everything. If a first-degree relative, a parent, sibling, or child has colon cancer, your risk is approximately double the average. If they were diagnosed before the age of 60, we typically recommend that you start screening 10 years earlier than the age at which they were diagnosed. So for example, if your dad had colon cancer at age 45, I need to look at your colon at age 35. Those are the guidelines. And in my clinic, family history is taken very seriously. And by the way, family history does not just apply to colon cancer. High-risk polyps or extensive polyp burden in a family member is treated in the same way. Okay, so let's talk about that trap I mentioned at the start of the video. If you've had IBS for years, and a lot of people have, it is incredibly common, there is a tendency to attribute every new gut symptom to your IBS. Something new happens, and your first thought is, oh, it's just my IBS acting up again. And you know, I completely understand why. Because for years, every stomach issue has been your IBS. It's a natural assumption, even a rational one. But this is something I really want you to hear because it can lead people to dismiss symptoms that actually need attention. People who have IBS can also get colon cancer, and having IBS does not protect you from colon cancer. And the symptom overlap means that if a cancer is developing in someone who already has IBS, that person is at the highest risk of dismissing it because everything fits neatly into the story they've been telling themselves for years. So what I want you to develop is a sense of what's different, not just worse. IBS has bad days, bad weeks, that is normal, but something that doesn't fit your usual pattern, a new kind of pain, blood that you haven't seen before, unintentional weight loss, symptoms that wake you up at night, fatigue that feels like something more. Your baseline is your most powerful tool here, and you know your gut better than anyone. If your gut is doing something it doesn't normally do, even when your IBS is bad, that difference is worth a conversation with your doctor. Not a Google search, a real conversation. And I would recommend saying, I have IBS, but something feels different and I want to talk about it. That's all it takes to get the ball rolling. When a patient tells me something feels different, this really gets my attention. Let me be practical about this because I find that people leave videos like this not really sure what their actual next step is. So let me be direct. You should talk to your doctor about a colonoscopy now if you are 45 or older and have never had one. This is standard preventive care. It is the same category as a mammogram for breast cancer or a PSA for prostate cancer. The whole point is to find polyps before they become cancer. That 10-year polyp to cancer progression window I described, that's exactly what we're using. You should also get a colonoscopy if you are younger than 45, but you have any of the red flags I just went through. Age does not make red flags less important. Colon cancer in younger people is rising, and you can check out my video on that on my channel as well. I have personally diagnosed colon cancer in patients in their 20s and 30s. I've had patients in their 40s who came to me convinced it was IBS, and it wasn't. If the flags are there, age does not change what needs to be done. If you have a family history of colon cancer or polyps in a first-degree relative, talk to your doctor about starting screening earlier. Work out exactly when, based on your specific family history. If you have a genetic predisposition, such as Lynch syndrome or FAP, meaning familial adenomatous polyposis, or long-standing inflammatory bowel disease, such as Crohn's or ulcerative colitis, you already have a significantly elevated risk and you need earlier and more frequent surveillance. Your GI doctor should already have you on a schedule. If you're not sure what that schedule is, call and find out. And if you've had a colonoscopy before and polyps were found, depending on the type and number, you likely need to come back for a repeat colonoscopy before 10 years. If you can't remember what your follow-up interval was, call the office. That information matters. So let me bring all this together then. Most bowel symptoms are not cancer. The vast majority of people watching this who have gut pain or bloating or changes in their stool have a benign explanation. IBS, something dietary, stress, all sorts of things. And when you get checked, you will almost always be reassured. And that reassurance, knowing rather than wondering, is worth so much more than sitting on it and hoping it goes away. But some of you watching this have been putting something off, maybe for a while, maybe you've convinced yourself it's probably nothing. Maybe you're a bit nervous about the colonoscopy, and so it's just easier not to think about it. So let me just say this. I have done tens of thousands of colonoscopies. It is one of the safest procedures in medicine. The prep the evening before is nobody's favorite night. I'll be upfront about that. But the procedure itself, patients are sedated, they wake up, and the vast majority of the time, I'm telling them that everything looks great or that I found a small polyp that I've already taken care of. The whole thing takes about 20 to 30 minutes max, and those 20 to 30 minutes can save your life. If the colonoscopy does find something, you want to find it early, stage 1, when we can deal with it cleanly and the outcomes are excellent. Not stage 4, when we are doing everything we can, but the window we had years earlier is gone. You do not get a second chance at early detection. So if you have the red flags we discussed, call your doctor this week. Not next month, this week. If you are 45 and you haven't been screened for colon cancer, make the appointment. If you have IBS and something feels different from your usual pattern, trust your intuition and get it checked out. And if you have questions about anything we discussed in this video, leave a comment below. I read as many comments as I can. My next video will be a more in-depth discussion about rectal bleeding, so subscribe to make sure you don't miss that information. Thank you for watching and take care of your gut. It matters more than most people realize.